Since most of you have already had a chance to see these gentlemen, this is a panel from Europe. The reason we have it on the show today is because, as probably all of you know, FHIR is a product of HL7 International as a standard development organization, and among other standards, FHIR is also developed all around the year-round basically, and although that's not obvious for those that don't really get involved all the time, you do have an option to interact with the crowds 3 times a year when we have working group meetings in January, May, and September every year. And during these meetings, I get the chance to meet a lot of professionals from around the world. Literally hundreds descend on these work group meetings, and they usually last for 5-6 days, so they're massive. And it gives us a tremendous opportunity to actually network and try to figure out what's going on in the world. So I thought that it would be a very good opportunity to bring these perspectives also to the Canadian landscape so that you get a chance to actually see what the world is doing with FHIR and don't get the feeling that we're trying to brainwash you with what we think is cool. So before I get going, let me introduce myself. My name is Attila Farkas. I'm the Director of FHIR Strategy and Implementation at Canada Health Infoway. I've been immersed in this space for a good few years now, and I was witness to the birth of FHIR 6 years ago, and I gotta say it's very, very exciting. I pretty much make it or draw the equivalence of FHIR to the birth date of the internet in 1989, because I'm certain that it's going to revolutionize the way we exchange medical information. So last time when we met was in, what was it? New Orleans. New Orleans, that was the last meeting. I had a chance to talk to this gentleman and another one, Richard from England, from NHS, and they gracefully agreed to come and be part of our panel conversation to see what the state of FHIR is around the world. And we were hoping for Richard to be here today as well. Unfortunately, he had a personal appointment that he couldn't miss, and he can't attend today. So he sent his regrets last night. I'm really sorry to see him not being here, but we're going to forge ahead, and we're going to make the best of it with what we have. So for the audience in the room, it's pretty clear that healthcare systems and the way healthcare is administered is very, very different, even within a country, never mind across borders. And so I thought that before we get going, I would like to introduce our panel and then to ask them, what is the healthcare delivery system? What does it look like in their countries? What type of players are present in it? What type of eHealth programs exist? So let's get going with maybe Norway. We have Øyvind Aassve, who's a senior advisor for the Norwegian eHealth program. He's in the lower left corner. We have Alexander Henket from the Netherlands, from Nictiz. Nictiz is a similar organization to Canada Health Infoway in Canada. And then we have Stefan Lang, German, who's health IT. Actually, he's one of the members of the technical committee for HL7 Germany on FHIR. So let's start with probably the far north and then come closer. Øyvind, would you like to start with talking a little bit about Norway and the type of eHealth agendas and programs you have in your country? I will pop up your presentation now. Maybe you want to drive it. Just okay, let me know when you want to go to the next slide. You may not see it, but...
Yeah. Yeah, the first slide is basically the one we're using in HL7 meetings to introduce Norway. So this is what the HL7 community is thinking about when they're thinking about Norway. So we have FHIR and elks and fish and northern lights. In many ways, maybe a little bit like Canada, I'm not sure. I think in many ways, in many surveys I see that Norway and Canada is actually comparable or being compared as quite equal in many ways. Yeah, if you go to the next slide.
Showing.
We are maybe a little bit smaller. Norway has 5.2 million people. General life expectancy is quite high, 81.5 years. Yeah, we have a number of doctors. In general, the health systems is you have the specialist care and the primary care, and the GP act as a gatekeeper. And we have a system where every person has his own GP, where he has to go up. You cannot just shop around to different GPs. You have your own regular GP that you are in contact with. Health care budget is 9.4% of GDP, and it's like many other countries. There's a lot of expenditure. We see that we cannot continue this way. It's increasing quite fast. So that's also the reason for why there is quite significant interest in eHealth, and why we also have now a Directorate of eHealth. Public funding, it's 85%, so there are some private hospitals, but in general, most people are at it. The main service is public. Yeah, and then we have the next slide shows the governance structure. This is a very simplified structure because that was the only one I had in English. We have a very much more elaborate, complex structure that shows the complexity of the whole structure. And the problem is they all have their decision domains, and they have yeah, it's literally many. I'm not going to say a number, but there's a large number of organizations. Which is hard to govern centrally, because they all decide on their part, on their turf. So, so we have it's split between two ministries, where the municipalities is under one ministry, and the specialist care hospitals are under a different ministry. The Directorate of eHealth, which you see now, is an agency or executive branch under the ministry, is quite new, and it was established 2 years ago. Before that, it was under the Directorate of Health. So, and it's actually supposed to cover the whole sector. The hospital regions are split into 4, so there are 4 hospital regions in Norway. So that's the basic structure. If you look at what's going on in the eHealth area, we can take a look at a couple of more slides. The next slide shows, which was a report to the Parliament in 2012, which has put up the vision that is one citizen, one record. So everything at least should be perceived as every citizen can find his record, and everything is available wherever he is, and all that stuff. And then there is still some discussion on what this means, and there are different concepts of realizing this. And it's also there is loads of different challenges, also because there are so many organizations, and for example, the GPs are private, and they don't want to maybe buy a new system and all that stuff. And all the municipalities, they decide on their own, so the central government cannot tell them to start using some system. But this is basically the long-term vision that we're working on. It's about consolidation. There is one project that actually was already started when this strategy was made. That's in the central region, where we now are, where they're buying international solution for the first time, or international EHR for the first time in Norway, because it's been national solutions for a great part. So that's one big project, and then the other one now, which got a lot of funding just a few weeks ago from government, which is already has been running for a couple of years, is the health data program, where the goal is to establish a health analysis platform where we can use the registries better.
Thank you, Øyvind.
Yeah.
Listening to your story, actually, I wasn't entirely sure that you're talking about Norway. It almost sounded like Canada. We have very similar challenges in this country. Okay, so let's jump to the other side of the continent and talk to Germany. Stefan, I have one horroristic slide that you sent me, and I thought our life was bad. So let's take a look at this one, folks. Let me just put it over.
Yeah, I didn't see the slides of Øyvind. I think I don't know why, but it doesn't matter.
So it's on the screen. You can talk to it.
Okay. So what you are looking at is the structure of the German health care system, or even the eHealth care, whatever. I won't tell you in detail what this all is, because I don't know. If you do know, please phone me right away after the session and tell me. Okay. But so it's just very complicated, because we are a federal state. We have several organizations on the national level. We have several organizations for every state, every over 16 states. And these are, even for private practices, different ones for the dentists and different ones for the hospitals, and several other organizations who care for healthcare and who care for, payment, of course, and who care for whatever has to be transmitted electronically. So the main players in that game are three organizations who represent the hospitals, which is called DKG, the Hospital Society of Germany. We have the so-called KBW, which is the organization of the private practices, apart from the dentists, who have their own organization, which is called KZBW. So you find these somewhere near the top of the diagram.
Yeah, I removed the diagram. I think it was enough for a moment.
Nobody wants to look at that for longer than a minute. Okay. So, but these are the three core organizations from caretaker's point of view. Of course, we have insurances. Our healthcare insurance system is mostly public, so 93% of the population is insured with public health insurance. There are several companies that do that, but they have to fulfill really hard requirements to be public health insurers. And 7%, obviously the more wealthy ones, have a so-called private insurance. So, if you have private insurance, you wait 2 hours for an appointment with a doctor. If you are publicly insured, you wait 2 months. So that's the structure of the insurance system. Obviously, we have a Ministry of Health, which is national. Not everything in Germany is nationally organized, but health is. And all these major organizations, including, of course, the Ministry of Health, have a joint national committee, which is called the GBA. And GBA finally decides somehow what has to happen in healthcare regarding treatment, regarding payment, and regarding digital transition. So, then there's one company, it's called the Gematik. This company is very unpopular in Germany because it took very long to fulfill the basic requirements they had, which was rolling out some health insurance card, the very infamous German health insurance card. They are currently rolling out something called the telematics infrastructure, which is just a way for medical organizations, practices and so on to communicate in a safe and data-protected manner. So Gematik is the company that actually does the German nationwide infrastructure.
I see. Okay, it sounds pretty complicated.
Just one thing? Okay.
Sounds pretty complicated. We just wanted to get a sense as to who are the major players in the field.
Yeah.
And the next question will go towards seeing how FHIR is relevant in this. But let's give Alexander a chance to also talk about the Netherlands.
Okay.
All right. The Netherlands is this small country that surrounds Amsterdam. We have 12 provinces, but those provinces do not work the same way that provinces work in Canada with their own territorial area and their own laws and all that. We have one country, and each of those 12 provinces is under the same national governance. But talking about governance, we do not have one system per patient. Patient data is at any given care provider he has ever been. And those care providers are pretty autonomous. They do work together whenever they are forced to get money for it, feel like it, or see their own business needs. But generally, you cannot tell them to do anything. You can persuade them into doing something. Just like in Norway, each patient in the Netherlands, and we have 17.2 million inhabitants, has his own GP that also serves as a gatekeeper for secondary and tertiary care. We have around 9,000 of those GPs and about 2,000 pharmacists generally available to you. You have freedom of choice for pharmacy, by the way, but you have a fixed GP. Mm-hmm. You can end up in any of our 80 to 90 hospitals, so that's about it for the landscape there. And we have generic hospitals or public hospitals, obviously private hospitals, but also university-attached hospitals where they do research of some sort. And there's a difference in funding between those two. Our Ministry of Health was always sort of leaning back and let the market handle the advancement of eHealth. But recently they've become more active, and they've come up with a national council where they try to get a better grip and direct the market a little bit better, partly because the market asked them to do so. And at the same time, by the way, always says, well, as soon as you give us new guidance, please also put money where your guidance is. Otherwise, they are slower to react.
Certainly.
The healthcare system is in part overseen by our payer community. We have 9 payers, and 89% of the Netherlands is insured at 4 of those 9. So we have the big 4. And those 9 companies have 89 brands that they operate with. They are made responsible for keeping the costs low. We're about 14% of our GDP and counting right now, which is about 95 billion euros. And they collect quality data and try to persuade or force the care system to perform better and be more efficient in that way.
So from the sound of this, Alexander, I see that you are probably struggling with similar challenges, that you have a lot of stakeholders in the market, you have a lot of agencies that try to sort of guide and regulate the market. I was wondering, what do you see that FHIR's relevance is to these eHealth programs? Could you talk to what is the vendor or industry engagement in all this, and how has FHIR been accepted, or how well is it known in the Netherlands? And let's go backwards this time around.
So a little bit of history around there. The Netherlands has been a messaging country, an e-health country since the beginning of time, shall we say. So we've done them all. Edeffect, HL7 version 2, version 3, messaging just like Canada, CDA just like other parts in the world. And our biggest drivers for FHIR have been greenfields. As it usually goes with something new, you'll have greenfields with less history to maintain. And our biggest greenfields are mental health care, where they use FHIR since STU version 1, the Brave Souls, to do serious game provisioning and see progress for people with ASS. I forgot the syndrome name, in English that is, but it's, no, can't remember. It's one of those syndromes that serious gaming can help you with to get better. And the other big driver is actually the patient. We have set out in a program called MEMIJ, MEMIJ, to actually enable patients in a personal health space to gain access to data normally residing at care providers and take control of their health with that. And when we asked the community of vendors that implements this, so what do you want to do? Do you want to play catch up with the last 30 years of healthcare standardization, or do we need something else? The definitive answer was we need something else. We preferably want to do everything in one standard. And there is only one standard that comes to mind that does what we want, and that's FHIR.
I see. Okay, thank you. That's interesting. Part two of that same question was sort of, do you see the industry rallying behind this in the Netherlands?
The industry is a big word. There's an industry with investment in large investment in V2, V3, and XDS. And that industry is sometimes very willing and sometimes struggling. Mm-hmm. But all in all, they're not rallying against it, and they're trying to get with the program. The industry, for as far as the patient goes, for as far as mental health goes, and for as far as most of the rest of the care, by the way, too, goes, are embracing FHIR. And they're really seeing the benefits as advertised. So ease of use and flexibility, speed, cost reduction, and all that.
Thank you. Stefan, we have a technical question for you. So what's going on with FHIR in Germany? I know that the away team from Germany is usually very involved in HL7 activities. So can you tell us about that?
Yeah, that's true. Involvement is one thing. FHIR is starting slowly, has been starting slowly in Germany. We of course do some things like base profiles for Germany, which is a thing we do in HL7 Germany. What just is really kickstarting FHIR is basically the follow-up to our eHealth law, which we have since 2016, and where the three parts of which I talked earlier, the hospitals and the private practices and the dentists, each of these organizations have to do some specifications on how the patient can get his or their structured data from a practice and a hospital and a dentist, and how these organizations, the medical organizations, can, for example, switch their IT systems from one to another, and the law says that has to be done by some standard. So these three parts of our healthcare system have totally separate possibilities how to do it. They can decide for themselves, but the one for the private practices, just in this February 2018, decided we use FHIR for that. So that's a really a starter for FHIR from a more or less official side, because the first specification with FHIR is has just come out by the end of March, and this will be part of the German interoperability directory. And when it is there, all companies that do IT systems for private practices will be enforced by law to have FHIR within 2 years.
I see.
So this is a big thing, because I think when the breakthrough is there, when they already have FHIR, they will see the advantages and will use that to gain an advantage on the market, which is what the vendors think, and of course will do that by giving the practices advantages by using FHIR.
Right.
For example, easier access for the patients.
So that's really
yeah.
good news then for Germany, right? Because it's, by the sound of it, a greenfield opportunity, and it's also legislatively supported.
Yeah, it's definitely very similar. It's a kind of greenfield. It's not a special area, but it's just a thing we don't have in Germany. Of course, it's very similar also to the GDPR, which demands the patient has to be able to get that data in a structured manner. This is also what's driving currently the vendors and the practices. And that's mainly what's going on. We also have some university-driven initiative in Germany, which is called the Medical Informatics Initiative, which is born and heavily funded by the government to just get healthcare IT to the 21st century. We're still somewhere in the 1990s here in Germany in some ways. So many of the universities taking part in that initiative also say we will use FHIR, we use FHIR for that. That's something that will also happen within the next, I think, 3 to 5 years. So FHIR can have a good future in Germany, I think.
Definitely. Thank you, Stefan, for that. So Øyvind, let's go to Norway now. And if you could tell us a little bit about how the eHealth agenda that's getting afoot in your country is embracing FHIR, and what is the market saying about it there?
Yeah. As I mentioned, we have a number of big programs like the health platform or the new eHR purchase in the central region. We have the health data program. And all these huge projects, they are pointing to FHIR. So that is one thing. We also see that we have in the Directorate, we have actually a Directorate that have the policy authority, but we also are developing national solutions. And in these solutions, there are a lot of use of FHIR already, both in the Directorate actually, and in the rest of the sector and the country. So we have a list in HL7 Norway, who has who has been responsible for trying to coordinate and secure a good use of HL7 standards in Norway. We have a list over FHIR initiatives that we have seen, and it's that are in production or under development or planned, and it's it's now 120 plus interfaces. So we have said, like, we're a limited small group of a few people. We have said this is not longer something we can do. We didn't have too much CDA. We didn't have too much version 3. But the interest and the traction that FHIR has is not possible to govern with a voluntary-based organization. So we see a lot of interest, and we see also some of the bigger projects that have more short-term delivery than these huge programs, like the National Prescription Service, and also the Welfare Technology Program, which is how to use more devices for security and help for people living at home.
So
we are now working together with the Directorate, and we see that the Directorate is taking a stronger role. And with regards to the vendors, with the vendors that we have been in contact with and who has implemented this, there's a lot of positivity. We actually, our main vendor in Norway, which is DIPS, which have 3 out of the 4 regions, where the 4th region now is doing a purchase, implemented at Oslo University Hospital already in 2015, actually, the first couple of interfaces on FHIR, and that was already done in DST1.
All right.
So there is now, I feel actually the last 6 months, it's been a lot happening. All the signals are pointing to FHIR, the big programs are pointing to FHIR. There is so much, it's hard to keep up because projects are just starting implementing FHIR without telling anyone. So we, HLC Norway, our Directorate, we get to know this about when it's
actually that's a very good point. That's a very good point you're bringing up, because my next question was trying to tease out whether or not you have any plans, or even better yet, any formalized programs in place that would focus on collaboration for maybe baselines, to have technical events where FHIR interfaces are tested. Do you have anything in this area? Would you be able to talk to that?
Yeah, so the fact is now we have started, we have a project now which is called the Roadmap Project for standardization, and which has both short-term and long-term deliveries. So the short-term deliveries is we need to take a grip on FHIR and everything that's happening now, or it will be hard to rein in at a later point. So we want to establish, or we're building now under construction, which is already being shared. So it's live, but it's a site where we want to build a community, share practices, share profiles, share guidelines. We need to make the guidelines first, though. But this is what we need, what we try to do now to handle the situation, because it's not good if we have so much going on and people are doing it in many different ways and using FHIR wrong, because there is you can still do that. It's a flexible and easy standard to implement. So we want to secure, we want to make sure that we have the basic governance ready and try to secure that people are doing this in the right way. And then the other, and also what we're going to use with how we're going to face, what's the strategy for existing standards, but then also what is the long-term strategy? Because we haven't really had from the central level a clear strategy on FHIR. And that's not what we're calling it now either. We're going to make a roadmap for standardization. We want to look quite broad for interoperability and standardization. And there are so many topics, and it's important to have an integrated view on it. So we're looking on what we're going to do with document sharing, document exchange, messaging, data sharing, but also more concrete use cases where we see there is need for standardization guidelines. For example, with regard to the health data program, what are the ambitions with taking data in and out of registries? Registries have very aggregated variables, which is can be hard to represent directly. So we see that maybe we should use information models and FHIR to exchange that. We have interoperability against medical, what do you call it in English, medical technical devices, both home devices and hospital devices. We have standards for reporting, like typical schema solutions where you fill out the form and then you send in. What are we going to do there? You have the closer integration with suites, where you can extend this based if you have a standard interface, typically kind of smart on FHIR use cases. What are we going to do with regards to some regions are working with the closed loop medication, and what are the connection to standards, logistics standards like GS1? What about in Norway, in Europe? There is some regulation on IDMP, what for medication, identification of medicinal products. How will this come into the picture? They have information models, but they also have identification of both products and substances. So maybe that also will influence terminology choice, like SNOMED and stuff like that.
Definitely sounds like a full agenda. Thank you very much for that.
What we do with metadata, with DICOM and VADO and all that stuff. What is the interface between if we want to use ontology-based terminologies? How will this affect our information models, for example? So we're going to take it a little bit step by step, but we have a work plan now for making a strategy that is quite wide, broad, to see the whole picture. And the advantage with FHIR is that it covers a very broad range of interoperability use cases, which makes it a very promising candidate. So we're going to research this for the next year probably, and start using it in short term, but also try to look at the big picture and how we can create a continuum of interoperability across all the exchange scenarios.
Thank you. Thank you, Øyvind. So let's go to Germany now. I know personally that your team there in Germany, Stefan, has been working feverishly on FHIR baseline. Would you be able to tell us a little bit more about that, and whether or not you have technical events or anything alike that exposes this?
Yeah, sure. So yeah, you just mentioned we have some well-developed base profiles. They are still not yet balloted, but we do have these for just the specialties we have in Germany, like the identification numbers or some specialties you just don't have in other countries. So these are base profiles. They are available on the usual tools. That's Simplifier, of course. Also on the FHIR registry, the international one. And we also do some use case-based profiles. For example, we have the medication plan, which is development of the medication further development of a medication plan we have already in Germany in a digital way. We have just starting a project concerning consent management, which will try to combine IHE and FHIR, because IHE, APPC and the BPPC profiles are simply there. We have especially the bigger hospitals in Germany who use IHE, but they also want to use FHIR and use it transparently if it's possible. So what we are organizing in Germany, we have the technical committee for FHIR, we have the interoperability forum, where we meet 4 times a year, not only regarding FHIR, but we have the special FHIR breakout there, where we discuss FHIR issues and develop on whatever is coming to our ears. Because we don't have a real strategy, well, we're just more like customer-driven development, because we just, if we see somebody has a problem and wants to use FHIR, we just support these companies and these people. Of course, we do support organizations like KBV to get FHIR right, because that's really an issue, not only in Norway, in Germany too. You have to just catch the people and catch the companies who want to use FHIR, to teach them how to do it and show them. So it's really education, it's tutorials, it's workshops, and that's also what we do.
Okay. You don't have
yeah?
Excuse me, you don't yet have a FHIR connected on, do you, in Germany?
We don't have a FHIR connected, and we just use our tools. We have an open discussion on Zulip in the FHIR chat, special German or German, Austria, Switzerland stream, but we don't have special connectathons or similar, not yet at least. It's just I think the bigger companies that are definitely involved in FHIR right now, they just want to keep their things covered. They don't want to show what they have, but they do indeed follow our base profiles or start doing so. So that's I think a real big thing to keep an eye on.
Right. That's good news
to keep a track that a national identifier is a national identifier, whoever uses it,
right.
And you can identify it across use cases.
Thank you very much for that, Stefan. So, yeah. Alexander, I think it's not a secret for the HL7 community that the Netherlands was probably the most eager nation that went ahead and immediately started creating baseline profiles for FHIR, even as far back as DSTU2, right? Can you talk a little bit about where you are on that roadmap now, and where are you going? What's the adoption rate? What kind of technical events do you have around it?
Right. So we're actually on it since STU1. So those brave souls I told you about earlier, they actually run in production the STU1. And the word that I couldn't remember was, let's get it back to the screen, the autism spectrum syndrome. That's the one that they have the serious gaming thing for. So, like you, I was at the birth of FHIR in 2011, at the same time where SIMI started the functional modeling. And very soon thereafter came FHIR, which is based in the Netherlands, and still one of the founding fathers with Graham Creve to advance FHIR to where it is today. And FHIR is a Dutch company, so you can imagine that they had to swallow the bitter pill, as we would call it, a little bit the first few years, because Netherlands was very deep invested in other standards at the time. It took a while for FHIR to get going, because people already had solutions in place, and greenfields weren't yet developing new stuff. But once they did, say 2014, 2015, on a growing scale, it soon became clear that if everybody starts developing profiles, it's going to be a Wild West, and we don't want this. So we very soon got together, and we as Nictiz in this case, where I work, with HL7 Netherlands, the official affiliate, and said, look, are we going to let this happen, or are we going to do something? And it turned out we were going to do something, so we came up with a FHIR council and a validation team that has a first and foremost task to educate people about what to do, what not to do with FHIR, try to make people aware of what is out there rather than having them develop stuff themselves. And finally, create that national set like the US core, but then the NL core. Our story is similar to that of Stefan. We also host this on FHIR, the FHIR platform. And we started out with a couple of administrative thingies like patient and organization and practitioner role, just basic administrative stuff. But we have much more in the works. The bigger initial thing that we started out with in 2015 was a collection of, say, 30 to 40 resources that we had to profile for stuff like payer information, all the way up to vaccinations, labs, medication, allergy intolerance, alerts, or flags as they're called in FHIR. All this driven by our collection of functional models. We call them HSIMs in English, health and care information models, and they're not unlike DCMs, although I'm unaware of how DCMs are perceived where you live.
Right.
Or even if it's a known term, detailed clinical models. It's our functional modeling, which also touches with the topics that Øyvind talked about, which is the SNOMED ontology and other bindings that we need to do, obviously, to get this functional models thing going.
Perfect. Well, thank you very much. I would be actually very curious. What do you think the delta is between the US core and the Dutch STU3 baseline?
I don't know is the honest answer.
Okay.
I believe the US core is also largely rooted in the administrative domain, because once you venture into more clinical domains, it becomes increasingly hard to establish one thing that goes for the nation.
Right.
You're much more likely to go into use cases of some sort.
Right. Well, this was more of a winded way of me asking you if by any chance you guys got started from US core and see if it's applicable to the Netherlands, or did you actually go from your requirements straight into modeling that?
We went to our requirements first and tried to talk to people on topics that sometimes really simple topics like name. We ended up talking with Simone Heckman, for example,
Germany.
a colleague of Stefan, because name parts in Dutch are not unlike name parts in many other parts of the world, including Spain, Italy, France, and Germany. So the solution that we came up with is actually reusable between those countries. So it's not a Dutch thing. It's at least a European thing, and anybody else interested in prefixes like voorvoegsels, something people usually cannot pronounce, they'll know how to do it from the international specifications. They have become a part of the international specifications, and we just call upon them.
Right. Well, thank you so much for that. We only have about 5 minutes left, and then some time for questions in case the audience has any. So I would be curious to see, where do you see the next big thing that is expected to hit us when it comes to fire? Where do you think the next big push is going to be?
Is this a question to me?
Yeah, we're going to go around the room again.
All right. Our next big thing will be on a boring topic, but very important, which is versioning.
That's cool.
We've been profiling STU3 for the last 2 years. Our FHIR and we'll soon have questions like, okay, so now what? People have just started implementing. How many years do we keep working on our STU3 before we move the whole stack to R4 or some other version that comes after that?
Right. Okay, that's a very good one, actually. It's been sitting at the center of the minds of many early implementers. Stefan, what do you think is going to be the next big thing?
Well, the next big thing for Germany surely will be what I told earlier. It's the KBB thing, the deployment of FHIR in all private practices in Germany over the next 2 years, which is where we from HL7 Germany definitely have to support and will support that, because that's just a chance to get FHIR rolled out really, really widely in Germany. So that's a major thing that will happen in Germany. Of course, as I said before, there will be other initiatives, and we do our special profiling in that way, like the consent management or something like that. But definitely a private practice project will be the big thing in Germany.
Okay, thank you, Stefan. Øyvind, last word.
Yeah, well, I'm not sure how big it is, but the focus now will be on taking a more stronger central governance on this and helping all the different projects in the country who are already using FHIR or planning to use FHIR to use it in the best possible way. So it's we're under the process of making base profiles, which is important for them. So it's, I think within, I hope, let's see, I don't know how many months it will take, but to have this basic community built up with support, with tooling and guidelines within, hopefully within at the end of this year. That is our short-term focus, and then I'm also very optimistic for FHIR on the longer horizon, or in the longer perspective. So yeah, so there's a lot of things happening. So we have to try to keep everything under control.
Okay, that's perfectly cool. Thank you so much, Øyvind. I will turn towards the audience now, see if there's any questions that they would like to address to you. Okay, I see none. Oh, there's one. There's one.
Alexander, you mentioned that standardizing the clinical practices is fairly difficult. I was wondering if there was any movement in any of the other countries that were Germany and Norway to push and use FHIR to standardize clinical practice.
So let me repeat the question, because you obviously didn't hear it online. So if I got it right, the question is to you, Alexander. Understanding that standardizing clinical practices is a very difficult task, do you feel that you could tap into the work that's going on in the other European countries to sort of help with the standardization effort? Was that accurate?
Well, I'm wondering if any of them are making any headway in doing that.
I see. And the second part is if you have any headway into doing clinical practice standardization.
So standardization, we usually take it use by use case. So we look at referral or discharge or multidisciplinary consultation, or we look at appointments, or we don't standardize the full practice in one go. We try to do it process by process. and try to reuse as many things as we can between from use case to use case. And the way we normally do this is that we host expert panels with domain experts and stakeholders that represent those practices. Probably not unlike you would probably do it yourself if you do this type of thing. And we create an initial draft, host an open consultation or ballot is the term, and if necessary, we'll host another one, and then we put it out there for implementation. And we usually also already have an idea of who is going to implement it once we've written it. Otherwise, it would be shelved if we don't watch out, and then we have a lot of wasted man hours on something that isn't actually implemented.
Right.
Did that cover the question, or?
Yeah, that I think it is. Any other panelists would like to jump into this?
I can say that Norway, we have been working a lot with clinical modeling because our main vendor DIPS is actually based on OpenEHR. So Norway has been quite central in doing clinical modeling using OpenEHR. But we also had now we have a policy that in order for interfaces we're going to exchange, we're going to express this in FHIR, because it's for exchange that this really is the important part. What for OpenEHR, what you do inside your EHR system, it's okay, but if you're going to exchange it, it's going to be on FHIR, and that's how we're going to standardize on the clinical models for exchange.
Hopefully you find the collaboration and the power to do so. It's harder than it sounds. Okay, any other questions from the audience? Seeing none, well, I would like to thank you very much, gentlemen, for staying late in the afternoon at your present place to talk to us. I think it was very valuable to get insight into what programs are going on in Europe. I'm sure there's even more variety than what we've seen today, but it is a little bit encouraging to see that we're not the only ones struggling with these types of issues, and hopefully there's going to be light at the end of the tunnel. Thank you.
Thank you, Attila.
Thank you.
It's quite amazing what you have made with this international online panel. That's very creative.
Yeah, it was a pretty cool experience.
That's a shame
Perfect.
we
See you
couldn't
in
be there
Cologne,
to
in
learn from
Germany.
you.
Goodbye,
Yeah, sure.
gentlemen. Okay, so thank you for your patience with this. It was a little bit of a technical challenge to bring everybody together.